Thank you, Professor Howard Branley, for agreeing to talk to me today. Now, this video is for you if you, like me, would like to have the opportunity to ask a bunch of questions to a specialist in respiratory medicine whilst we are here right in the middle of a global pandemic of a respiratory virus. And Professor Branley was kind enough to, or foolish enough perhaps, to agree to answering a bunch of my questions today and doing it to camera. So I really appreciate you joining me and agreeing to that, Professor Howard. It's a great honour, actually. I don't think I've spoken to many professors directly, so thank you so much for that. Dan. Oh, thank you. Is there, before we get into it, so I've got a bunch of questions that I want to ask you, but before we get into it, is there anything you want to say about what we're doing today?
No, hopefully that this will enable people who are worried, who've got COVID or had COVID or COVID symptoms, about what's going on, trying to make some sense of all the misinformation that's out there, which hopefully is reducing, and hopefully helping you find a way to get back to your normal good health.
Fantastic. And hopefully we'll ask some questions as well that are not necessarily to do with COVID, because, you know, you were a respiratory specialist before COVID came along, I imagine.
Absolutely.
Fantastic.
Absolutely, yeah. I'll go and say most of my work over the last 3 or 4 months has been COVID. So seeing something other than COVID is a welcome relief.
Is that a novelty right now?
It is. It is.
Fantastic. Right, let's get into it then. So I'm going to start with some questions. So in terms of the questions that I've got to ask you, I was very lazy and I asked some other people to tell me what questions they would ask if they had an opportunity like this. So a couple of them are mine, but the majority of them are actually from other people. So I'm going to start with Rita's. And Rita asks, I'd like to know what about the coughing, wheezing, phlegm oozing conditions interested him that much to make it a career?
What an opening question. Yeah, when you put it like that, it doesn't seem like the best career choice, does it? But whenever patients say that, they ask me about that, I say, this is why I'm not a gastroenterologist, because I can deal with sputum, but I don't want to deal with other people's poos. Okay? So I'm quite easy with sputum. I wouldn't say I fell into it. My love going through medical school was infectious disease, and I trained in Liverpool as an undergraduate, which is a big tropical medical centre, and then went over to Africa as a medical student and did some work in sleeping sickness and leprosy. In fact, I watched the World Cup final of Italia 90 in a leprosy hospital in East Africa. That's where I was at the time, yeah. And then the HIV epidemic came, and that swamped all the infectious diseases services, and I didn't feel that I really wanted to spend my life doing that. I like the oncology as well, and breathing problems, and I did some cardiology as well, but it just wasn't my thing. I liked the respiratory because it gave me a very broad brush of lots of things, of infection, of cancer, and of symptoms like breathing troubles, which is the thing that I most like to see.
So that's really interesting, actually, and I'm super proud because I live in Warrington and Liverpool Medical School is only up the road from me. So,
Indeed.
You know, you came to the best place as far as I'm concerned.
Indeed.
That's fantastic, and I'm really interested to hear that background, actually. So just before I go on to the next question, so what was that actual bifurcation point where you went from infectious disease to specifically respiratory medicine?
Well, infectious disease was really quite a small specialty back then, sort of looking at mid-90s. And I mean, it's a big specialty, but small number of centres. So you could either be, really, it was Liverpool, London, Birmingham. And very difficult. And some of the training programs were linked with microbiology, so in the laboratory, which wasn't really my thing because I wanted to talk to people rather than be dealing with the laboratory. So I did, when I came back to London from Liverpool, I did a rotation in West London, and I did some respiratory, I did some cardiology and a few other things. And it became clear, I do remember vividly, and some people think I'm crazy for this, but I did a tuberculosis clinic in Ealing Hospital. Tuberculosis clinic in Ealing Hospital is just absolutely chaotic. It's as if you have shipped in, 10 coach loads of patients from all over the world. Lots of them can't speak English, and it's just really busy. But it was so much fun because it's one of the diseases we can cure. And so here we were talking with people all around the world, and I love picking up little bits of languages. So I could say the odd word in this language or that language, and then it was just great. And I actually went back there subsequently as a consultant and ran the TB service for a few years. So yeah, and that's what, and I remember it was that which drew me into, sort of sucked me into respiratory. I thought I enjoyed it so much that the clinic had rushed past, and we'd seen God knows how many patients, and that was it. We're all done.
Yeah, I love the way you say it sucked you in, crikey.
Yeah, it did.
So I'm going to move on to one of the COVID questions that I've been asked to ask you, which is from Sarah. Is there anything that we can do to improve our respiratory system that would be of benefit should we get COVID?
Wow, there's a question. I think it's difficult because people have been locked down. It's not any specific supplement, which is often a question I'll be asked about. Do I take this tablet or whatever to improve my lungs? I think keeping yourself as fit as you can, and as doctors will always say, eating a balanced diet, not smoking. Okay, people smoke. We know that that's going to affect your lungs. And if you've got two things to cope with, smoking and COVID, it's going to be harder. I think if people who've got underlying conditions such as asthma or bronchitis, they need to make sure that those have been dealt with and looked after properly. So, have they seen their specialist nurse or the doctor recently? And then there's also people who may not have underlying conditions, but their COVID might be making their lungs not expand as well. It might be painful. And these people can benefit not only from seeing a doctor, but from seeing other non-medical specialists, like paramedical specialists, people like physiotherapists, people who can go in more detail about the actual mechanics of the breathing, which is very individual to a patient. And sometimes when I suggest this to patients, you kind of got to get past that blank look where they think, how is a physio going to help me? They get people walking, which is obviously important, but it's amazing the number of people with not just COVID, but all sorts of diseases who forget to breathe properly. And it's not a conscious thing. It just happens, is that their breathing rhythm is a bit abnormal. And I always say to them that there is a leap of faith that the physio will be able to help you with this. Don't just give up. Go and see them, and I'd be pretty certain that they could help.
I feel the need to interview some physios about this.
Absolutely.
So put that on the list. That kind of leads us into the next one quite nicely, which is again a question from Sarah. So if anyone suspects they've got COVID, is there anything they can do to keep their respiratory system working as efficiently as possible during their body's handling of that disease process?
Yeah, so...
Is it more of the same, really? You've just got to eat healthily.
It is more of the same, but it's also, I think what's very important is sometimes when people have breathing problems or it's painful, they don't breathe deeply. And so the bottom bits of your lungs don't expand. And they will expand, but not as well. The lungs are, if you know what a slinky is, the metal coil that walks down the stairs, the lungs are like two of those held up, suspended. So the top bit will open up, but the bottom bit, if you've ever done that, held up a coil, that takes a deep breath to stretch it open. And so if you're not doing that because it's painful or you're in bed and you're not breathing properly, the bottom bits of your lungs don't expand as well, and it will make you more prone to pick up infection. Germs that you might normally breathe in that you might be able to clean out easier. If you're not expanding the lungs, you're not replenishing that air quickly enough. And that's another thing where physio can be really helpful.
I love that slinky analogy. I think I'll steal that one.
Good.
Okay, going back to some non-COVID questions then, and probably a little bit connected with your infectious disease background. Jonathan asks, Do you kiss others on the lips, knowing the potential bugs that could be shared? So, Professor Howard, are you a kisser or not?
Not to my patients, obviously. We won't put that in the video. It's an interesting question, but I think the reality is, if you're kissing someone, a partner, or your children, most people will be living with that person or having at least close contact, and so if someone were to have COVID and you didn't know, and they weren't isolated from the rest of the family, then you could be picking it up from them touching things, from touching you. So kissing, yes, there can be, obviously kissing, you've got the upper respiratory tract, so there'll be more virus there. So I think if you're living with someone, and once you know that someone's got COVID, then you should try and isolate within the family. But before that, when you're living with someone, and it's similar when people ask about tuberculosis, is my wife, is my husband or whatever at risk, you're living with them. So the likelihood is you will have passed it already. So we don't advise people not to kiss their partners.
Their loved ones. But you don't advise us to go out kissing everybody in the street then?
That's an individual choice for you, but so long as you're within the 1 metre plus.
Thank you. I love that one. Okay, I'm going to move on to a question from Magic Philip. Now, Magic Philip used to be, I didn't know this about him, he was the magician that did my daughter's 3rd birthday. She's 15 now. And he was really good. Anyway, apparently in a previous life, Magic Philip was a pharmacist. And he asks, was dexamethasone, and I'm quite proud I managed to pronounce that, regularly used at the start of the pandemic before the recent publicity about its effectiveness, as far as you know?
Well, the answer to that is it may have been and it may not have been. Now, that's not just, I'll explain why I say that, is that, obviously I can't say what every hospital has done, but when people have an infection, the reason that dexamethasone is being used is that in some patients when you're clearing infection, your immune system is making chemicals and they kill the infection. Now, if that becomes an exaggerated or overzealous response, you've suddenly got more of the chemicals to fight off and kill things than you need. And that can inflame the lungs, okay? And that can be quite dangerous. So this is not something which is peculiar to COVID. We've seen this in other conditions before, and some which are not infectious in nature. And so what can be a dilemma with that is when we're seeing the sickest people is when we've got someone who may have had a CT scan and there's lots of shadowing, and the question that's going through our mind is this infection, is the shadowing infection, or is it inflammation, or is it both? Now, if it's all infection and we whack in loads of steroids, which is what dexamethasone is, we might reduce their immunity and actually infection can get worse. And if we don't treat it, because we think it's all just infection, we could be missing. So sometimes in the sickest patients, what we'll actually end up doing is putting a camera down under sedation and washing out the lungs, trying to see if there are any germs that could be isolated, and then to use the appropriate treatment. But sometimes you can't be sure because of the timing that it takes to get the results. You don't often have that luxury to wait. And so often what we'll do is do both. And there are different sorts of steroids. Dexamethasone is a tablet steroid. There's another commonly used one is prednisolone. But there are also intravenous ones like hydrocortisone, which you can get tablets as well, and methylprednisolone, which is like the industrial strength, where you're giving mega doses. So it's very likely that hospitals around the country will have been doing what they've done before. And in those people who are having these massive inflammation reactions, will have been using steroids, for sure. And because that's what normal practice would have been. I don't think it would have been a matter of routine, though, for everyone.
Okay. So I've been hearing things about a cytokine storm being one of the things that
That's what I was. Yeah.
Is that what you're talking about?
That's what the chemicals are. Yeah. So cytokines,
Right.
we need them, but if you go too much, then it's obviously not good.
And can you get those in other respiratory infections like influenza, for example?
Yeah, you can get cytokines. They're not peculiar to COVID.
Okay.
Yeah.
Right. Fabulous. Well, that answers that one. So I'm going to go back to a non-COVID related question, if I may. And this one is from Dave. Now, Dave likes some wacky things, so it's a bit of a wacky question, but he says, are there any breathing techniques or approaches that can help people with respiratory illness? And the reason he's asking is, as Wim Hof keeps popping up on social media. Now, prior to him asking this question, I didn't know who Wim Hof was, but he's some guy that does some crazy things out in ice and freezing conditions that, you know, perhaps you and I would not think about doing. Anyway, what are your views on that?
Yeah, I think Wim Hof is this Dutch guy that holds records for being in whole baths of ice and having his whole body, or as much of his body as possible, in contact with ice. Why someone would want to do that as a record, I don't know. But the question about can other specialists help, was it? Or
are there any breathing techniques or approaches that can help people with respiratory illness? I guess you're probably going to point towards the physios being...
Yeah, I mean, there will be. There are different techniques according to what you're trying to achieve. And so when I see people who and it will be respiratory physiotherapists who are the experts in this, much more than I am, and what they can do, they are expert in lots of things, but specifically probably the two things that I refer to the most is one for people who need help with expectoration or coughing up of sputum. So people who've got some phlegm and they're like, and they just can't get it off the chest. So there are various maneuvers or exercises that physios will teach them. Particularly, you can imagine a child with cystic fibrosis, this type of thing. But it's not, it's not, again, just specific just to cystic fibrosis. It'd be adults with various things as well. And people who've had infections who may find it difficult to get phlegm off the chest. But also those people, if it's not a sputum or phlegm issue, those who are having problems with their breathing, and sometimes people's breathing can become a bit uncoordinated and they're just not breathing properly. Sometimes people breathe in a rather shallow or too fast fashion, or it's a bit uncoordinated. And although it sounds crazy, you can't forget to breathe, because it's a thing we do without thinking, but the natural rhythm of it can be disturbed. And physios, my experience of working with respiratory physios over the years is they are excellent at sorting this out. And, patients come back.
Example again.
Yeah, patients come back and they say, wow, I didn't think that was going to help, but, I'm so good after I've seen the physio. Just this morning in clinic, I was talking to someone who said that exact thing.
Yeah? What sort of problem had they had without,
They'd had an infection on their chest. They'd got better from that, but the breathing wasn't right, and there didn't seem to be anything physical in terms of any either physiological or structural issue with the lungs, and they were having some slightly erratic breathing. And I said, the physio will be able to help you get this under control. Because another thing I see, and this is very common I see in patients with asthma as well, is if they get anxious, as we all get anxious about various things, it makes the breathing worse. And then the number of patients who've asked me, especially with COVID, when things have been dragging on a while, is saying, is it all anxiety? I say, well, it might be, but we need to make sure that there's nothing physical going on. But anxiety will often make breathing worse. And so the physios can help with it's almost like rebooting a computer, is just resetting the breathing and getting things back to a normal pattern. I have a young woman with asthma who's got that exact problem, who's been seeing the respiratory physiotherapist, and whenever she gets the anxiety building up, she goes and does her exercise and the breathing exercises, and she's right as rain. Just
on a tangent to that then, what sort of time frame would it on average take somebody to, relearn how to breathe more effectively again then if they've had those problems?
It depends on the individual, but some patients might only need a single session. Some will
Really?
some will have a couple of sessions, some longer. And that you've got to go with the expertise of the physio who, I think some patients will like just a one-off, but some will not want to come back, even if they know the exercises and manoeuvres to do. They'll still like to do it with the specialist with them. But, especially in this time, what's so great about video now is that we've got colleagues in physio and doing Pilates who can help people virtually through the medium of video. You don't have to physically go somewhere, which is great. And that's something I think that will stay after COVID.
Yeah. Oh, definitely. I think video consultations have been invaluable. Well, they have to me anyway.
Sure.
Back to a COVID question.
Okay.
How many rationing to 5? I did say I would only do 5 COVID questions.
All right.
Wendy asks, are people with rheumatoid arthritis or SLE, systemic lupus erythematosus, that are already susceptible to lung diseases if it left untreated, are they likely to have permanent lung issues if they contract COVID?
Not necessarily. I think that there's a number of reasons they might do. COVID, the sort of more chronic issues that we see are, well, one is a failure to get better, but that's usually fairly obvious because you don't make it out of hospital, or you got this grumbling pneumonia, but it's not something which will go on because you hopefully seek attention. But there are 2 things which we are seeing as issues related to COVID. One is that the lungs, if they're left very inflamed or infected, it can encourage scarring, or fibrosis is the word we use. My experience is that that's not so big an issue as we were concerned about. It can happen, and certainly it was viewed in the more sick end of the spectrum. The worse disease that you have acutely, the more the chance. And the other thing is that COVID is a condition which makes your blood clotting system tend to be more sticky, so it activates it a bit. And that can give rise to blood clots. Not necessarily the blood clots where you have a clot in the leg and it travels up, that can happen, but also clot just developing primarily in the lungs and not having travelled from elsewhere. So both of those things are very easily detectable, and we tend to use a test called a CT-PA, or it's a CT scan with the PA is a pulmonary angiogram. So you have an injection, and when the dye goes up and into the chest, it goes through the branching of the vessels, and you take the pictures and you can see if there's any clot there. And at the same examination, you get the whole of the lung, so you can see if there's any scarring or any ongoing pneumonia or indeed any other problem. So
wow. What's that called again?
A CT-PA, CT pulmonary angiogram. Now, with the specifics of someone who's got rheumatoid or lupus, then both of those diseases can be associated with what's called interstitial lung disease, which is the spongy tissue of the lung becoming disease, either inflamed or scarred. So that can happen. There's also the medications that people might have for those conditions can cause abnormalities that can mimic pneumonia. It can mimic some airway problems. And then the spongy tissue called the interstitium or the lung parenchyma, those things can become inflamed or scarred. So I think people who have those conditions don't need to be excessively worried, but it's just we would keep a bit more of a closer watch on those people during recovery, because if they've already got some scarring, we just want to make sure that scarring is very important, that you don't just take a snapshot, you look at it sequentially, like with interval scans or interval lung function testing. So it's certainly want to keep a close watch on those people. And
I suppose indeed a lot of those people are going to be in the group that have been shielding anyway during the lockdown period.
Correct. Yeah.
So hopefully they've managed
especially
to dodge.
Some of the medications which can be quite strong. There's a whole spectrum of drugs which suppress the immune system. If you're definitely on the stronger end, then you will be shielding. Okay,
last question on COVID then. Kath asks, she'd like to know if you think post-COVID patients who didn't have a respiratory lung disease before getting COVID will now have long-term respiratory issues.
I think the answer to that is most no. I think they'll recover. So, if you've got a previously fit and well person, the expectation is that they will recover. There will be some who might develop some issues related to the breathing, like the scarring or blood clots. But the blood clots are treatable. They might need some treatment for up to 6 months or so.
Are you talking anticoagulants there, or?
Yeah. Yes.
Yeah.
So I've got several people who are on anticoagulants. But the expectation is that these people will recover. So, like with any disease or any condition, you can know, a doctor who says 100%, you can't take 100% because no one can say what will happen in an individual. But by and large, most people will recover and fully recover. And it's just, it can take a bit of time. And because we're still new into this outbreak, it's only really 6 months. It's not even 6 months, really. We are finding that by about 3 to 4 months, most people will have recovered. And often it's much quicker than that. But it's not at all unusual for me to be seeing patients who've had COVID in March or April, and now we're coming towards the end of June. They're still having some issues.
What sort of issues are they sort of getting on the tail end, would you say?
I think the commonest things I'm seeing are people are breathless, or they're having discomfort in the chest. And it can be very variable. It can be chest pain, it can be chest tightness, it can sometimes be a heaviness on the chest. Someone said to me yesterday, a patient, he said, it felt like I've got 4 1-pound coins sitting there on the chest. So it's not super heavy like a brick, but just that's how he likened it. So these things, and sometimes we'll do scans, blood tests, breathing tests, and everything is normal. So there are no complications, but we know that this is not a one-off in terms of the patient isn't unique in having those symptoms. I've seen lots and lots of people who've got those symptoms who have tests to make sure they haven't got any of the more serious complications and everything's fine, but they're still getting this sort of stuttering improvement. And what we are seeing is that they do settle down. Sometimes, you'll get the odd case where it takes a bit longer. And I will sometimes involve other specialists as well, particularly cardiology, because people who've got chest pain and breathlessness, it's not always the lung, which is the culprit. And so we will see some people who might get pain when they're breathing or they're breathless because the lining of the lung, called the pleura, it's like a sac or a membrane that the lungs sit in. The heart has one called the pericardium, and that can be inflamed, and that can be jolly difficult to pin down sometimes, because you might see it light up on an MRI scan that the cardiologist will use something called cardiac MRI, but not always. And sometimes there's a bit of fluid there, and it's just, imagine if the heart's beating and you've got this bag that it sits in. Every time it beats, there's a bit of stretching, and so it will hurt. And the same with the pleura for the lungs. Every time you breathe, and that's why people, if it is painful, they might underbreathe, and that becomes quite an inefficient way to breathe.
So are you saying then that even though some of these people might have had COVID, that they're getting these other symptoms that are perhaps more cardiac related, and those cardiac symptoms aren't related to the COVID, but they're getting identified as a result of the tail end of the symptoms of recovering from COVID?
Not necessarily. They can be COVID, primarily related to COVID. I mean, there are some COVID patients who get, and this has happened with other viruses before, where the heart muscle, the myocardium, becomes inflamed. It's called myocarditis. And that's it's relatively uncommon. If you think about the vast number of people that have viral infections, all year round, and then the number that get myocarditis is very small. But it can happen with COVID. And I think, what I'm saying to patients time and time again is COVID is weird. And it's, we don't know everything about it at the moment. So whilst it's probably not anything serious, I can't necessarily discount certain symptoms as being related to the COVID. And so it's important that we do investigate these things and make sure that they're not anything, A, that's identifiable related to COVID, or B, that it's something which is nothing to do with COVID, that they've just got something else going on as well, because that can happen. All the other things that happen to people normally are still happening.
Exactly, and I think that's probably quite a problem, really. I mean, you just take me onto a nice segue there to one of the things that I was going. See, I've got a cough. I don't think it's COVID, but if I go out in the street and I cough, I feel like a pariah. I feel like a leper. It's almost like we're in a global pandemic, and if you start to cough for any other reason, I don't know what mine is. It could be all the pollen and all the rest of it, but it's almost like you daren't go out if you've got a cough for any other reason. But are you finding any patients experiencing that and worried about that coming to see you?
Absolutely, lots. But typically the cough that we are seeing with COVID is typically very dry and tickly, very always like an asthmatic cough when people not necessarily getting the phlegm. It's just very irritable in the throat, and it seems to be triggered very easily. But if I'm speaking to someone, and they start coughing, it's very distinctive. The first few COVID patients that I saw, I'm thinking this cough seems very distinctive. But if the cough can become wet, and if it is a wet cough, so there's phlegm there, then that could mean potentially that there's some secondary infection. So after a viral infection, we will sometimes see that bacteria can get in a bit more easily and cause infection. And so that might then lead on to some antibiotics if that's what the doctor who's seeing that person feels is warranted.
Right, I'm going to get back onto my questions now.
Okay.
So I did a little bit of digging around you.
Oh dear.
A bit of detective work there, Doc. And I see that you've got a lot of super reviews on Doxify. So I want to ask you, Professor Howard, what is at the forefront of your mind when you see a new patient for the first time, and why?
Wow, that is a good question. Yes, Doxify there are. In fact, my secretary, she phoned me today just to say, have you seen the new reviews on Doxify? That's great. It's nice. It's what a patient, if I were a patient, I'd be looking to see what are other patients saying. So what do? I think one of the things is people that come are often terrified. And some people can't even vocalize the word that they're worried about, cancer. It's always that. And there's almost a thing that if they say the word, it somehow ups the ante and it makes it more likely. So I always ask people, is there anything specific they're concerned about? And I might, even if they don't say that, I might, if it seems that's where it is, we'll bring that into the conversation. But I want people to be able to, the number of times that people say, oh, this might sound weird or stupid. Okay, don't worry. I've been doing this for over 25 years. The number of things I've heard, I'm sure it will just sound run-of-the-mill. It won't sound abnormal. So I want people to be able to come in to be able to tell me anything, knowing that it's confidential. So anything they say, I'm not going to be writing to their employer. Their other half won't be finding out this information. They can tell me anything. I can then put that together into what I think is going on, because most diagnoses that I make are made from what the person's telling me. So I like to try and let people talk. It's a bit like just having some horses, and sometimes I'll just need to rein them in a little bit, because if it becomes very me asking the question and it's a yes, no, well, we could do a questionnaire, and you miss lots of things like that. So I want people to be able to talk, but, rein it in a bit when it starts going off on a tangent that's not relevant. And for me to be able to get them to a diagnosis as quickly as possible, and then with that diagnosis to then get them to the appropriate treatment. So the approach I've always been thinking, when it's more often people pick up things during their medical training and think, I don't want to be like that, rather than necessarily I want to be like that. And having seen, as we all have relatives who become unwell, I just think there's accessibility. So when people want to ask something, that's really important, that I think I could try and answer that. And I want to think that if a relative of mine was going to see the doctor, what sort of person would I want them to be able to see? I don't want someone to be all gushing and sort of falling over themselves to try and be nice, because that all seems a bit false. But genuinely interested in that person getting back to how they are, And being professional, but not missing things, and so being thorough and getting that person back to at least where they were, hopefully, or hopefully better. That's my aim. And I think, well, would I take a relative of mine to see this person and say, if I think they weren't, then that's not the sort of person I want to be. So that's what I try to do. And I think the reviews that you mentioned, I mean, it's great when I read those. It makes me blush sometimes, thinking, wow, that's really nice. But it's, that's what I try to do. And I think that's hopefully what everyone is trying to do. It's just, that's the patient's feedback. It's all anonymous, so I don't know who's left what. I don't even know if any given patient has left any feedback. They all get sent a link, and the Doctify is a separate company. So if someone were to write a negative review, and fingers crossed they haven't, then I wouldn't be able to veto that and say, they don't want that.
Don't publish that one, yeah.
Yeah, I mean, obviously, if there was something libelous in there, then the company, I think, wouldn't publish it. But, patients are all different. I mean, I remember reading one and wondering, I think they gave a 4-star review. I've had 1 3-star, a couple of 2 or 3 4-stars, all the rest have been 5-star. The 3-star was all about a secretarial service that I used to use. Not my current PA. Genevieve is just wonderful. The patients love her. And she's just so kind, genuinely interested, and sorts things out for them. And that it's spontaneously, we've got patients saying, wow, she's amazing. So that was related to that. They said, oh, everything with me was fine, but it was let down by the other thing, so I haven't used that company for a while. The other one was someone who was it was exceptionally good feedback, but they still gave 4 out of 5. And I remember reading that thinking, lovely words, but what more could I have done? What do you have to do to get 5 out of 5 from that person? But, it's the thing is, if you know what it's like, if you read a review on Amazon or somewhere and everything is, 5-star, you're a bit suspicious that it's all fictitious. So I think, getting some which aren't all top score it just reflects the, human nature, the way things are.
Exactly. And some people are hard markers in that they never give anything top marks, because to give it top marks is perfection. We're humans, so therefore we can't be perfect. So they can't give 5 stars. And if that's that person's way of looking at it, then that's got to be the person that gives you a 4-star one with some nice words.
Yeah, I think it's the words are most important, because I mean
Yes.
If you don't want to say anything and you do it, you could just put the star thing, but actually writing some words. And it's all, that when they're invited to do the questionnaire, there's no obligation to do it. There are some questions about the type of things that patients ask about, how was the consultation in terms of, how did you feel at ease type of thing, and did they get to the diagnosis, were they sort of any good type of thing as a doctor. But also this sort of friends and family test about, would you take a member of your family there, and would you recommend them? Would you see them again? And so it's really nice when people do write feedback. And I always say, I've seen lots and lots of colleagues, more than I could shake a sticker. And I think that always makes me feel quite proud that someone in the profession, and not necessarily doctor, it could be nurses, physios, etc. And I've seen them all, that they've chosen me to come and see. It always makes me feel quite proud and happy about that.
Rightly so, in my opinion. Okay, so getting into some of the things, I mean, you've alluded to some of the things that you've treated over the years. Is there a particular condition that's your absolute favourite to go, oh, I'm so glad this is in clinic today? What are they?
It depends on how you phrase it. If it's a symptom or if it's a disease. The symptom, it's difficult because the lung can't do much, but the sort of best detective challenge, if you will, is someone that's breathless, because you can think through the physiology of, for me, mentally thinking, we've got this oxygen in the air and it's got to get down these lungs, across the lungs into the blood vessels, tagged onto blood, circulated around the body, and then for the various tissues of the muscles to use it. And so you can think, very meticulously about the different processes and test appropriately, and often it's more than one. So that's always a great diagnostic challenge, and particularly if you're someone, if there isn't anything wrong, you can be unequivocal and say this is all good. So that's often reassuring. The people who've got troublesome cough, that's a lovely thing to see, because it can be so debilitating, and so when you can help those people, it's great. And sometimes it can be tricky, but we get there. And I think about diseases, I think the diseases where I feel that I can help that person to either cope with what it is or diagnose it and improve it. It's got to be the person who's worried that they might have lung cancer, because I think that's very early on, from when I was a registrar at St Mary's. Before we had all these electronic lists and things, I remember I used to keep in our office a list of the lung cancer patients that were in my clinic, and it wasn't many, no more than a dozen or so at any given time. But I used to, these are the ones who were on treatment that I was seeing rather than the boss at the time. And I would phone them every week. I remember every Wednesday morning, I would make a point, I'd work through my list, and I would just check up on them and give them a call and saying, how are you since your diagnosis or your radiotherapy or your chemotherapy? And now we've got excellent sort of cancer specialist nurses who will do that. But it was a lovely thing. I remember doing it, and it was, it didn't take long to make a dozen or so phone calls, but I think they appreciated it because they felt they weren't just sort of at the end of somewhere, and that there was no kind of continuity. So those patients, I think to think about the one condition where we know we can cure people completely is tuberculosis. It's just a dream to treat tuberculosis, because it can be tricky diagnosis sometimes, but you've got for respiratory where it can be like putting an elastoplast on something. We're just getting people to the next MOT type of thing with some conditions. But with TB, with a course of treatment, you can cure people, which for some condition, for specialists, that's a rare thing to say, we can cure you.
Yeah.
I like doing that.
And I mean, indeed, 100 or so years ago, that would be a fatal diagnosis.
Yeah, consumption.
Yeah.
That's how what our specialty evolved from. Respiratory evolved from TB clinics. Yeah.
Fantastic. So how old were you when you decided you wanted to be a doctor? And did you ever think about doing anything else? 16.
Yeah, it wasn't a lifelong passion.
No.
I was, and that's it, I was going into the RAF as a pilot, was what I wanted to do. That was always an obsession about aeroplanes. And then these things, unfortunately, put paid to that. So I couldn't be a fast jet fighter pilot. And I looked at what I was doing at school. My favourite subject at school was chemistry. I loved chemistry. I had an insane, mad teacher who was a one-off, and who used to teach us chemistry for his love of chemistry rather than because we were doing O-level and A-level thing. He'd cover the course, but we'd do a whole load of stuff that was never in the course. But it was just fascinating because this guy, and he was into amateur dramatics and was possibly a bit schizophrenic. So our lessons always used to start with him coming in and he would do the first scene of whatever play he was doing and be playing all the parts. And this would be the first 5 minutes. It was just like, this is crazy. And I remember other kids in the sixth form, we had 8 in my set, and I can't remember how many, probably similar. And they had the head of department, and they're all like, "Oh God, you've got so-and-so." I'm like, I'd had him all through school and got an A in my O-level, and I ended up getting an A in the A-level, and then doing a special paper, as it was called then, I think S-level, which I got a distinction on. And this is because he just infused this. And of our group of 8, we got something like 6 A's and 2 B's, because he was so enthusiastic about it, is that we just were like, wow, this is so interesting. And so with that love of chemistry, and I was also doing the other sciences as well and maths, I looked at pharmacy. And I looked, it sounded interesting learning about the drugs and things, but it did become quite more of a service thing rather than actually influencing people. I know it's changed a lot now because you do get pharmacies who are giving medical advice as well. But back then it was literally, you go, here's the prescription, right, there's your medicine, off you go type of thing. And, obviously checking with the safety and interactions. So I thought it was a bit boring after a while. And I did get, I got a weekend job, Saturday job in a pharmacist in Boots in Bond Street in London. Yeah. That's where I used to go. I used to work up there. And then over the summer, I'd be working there just all the time, kind of thing, like during the week. And so I looked at medicine because I thought, well, they always ask you in medical school interviews, why do you want to be a doctor? And I don't know what I said because it was a long time. It was I started in 1987 at medical school. And so there's obviously this thing about wanting to help people, but it's the most cringy answer you can't prepare for that question because it just has to sound natural. So I'm not sure what I said. It would have been something along those lines. But I'd done that job and I'd also been working as an HCA, like an auxiliary nurse in local hospital in East London where I grew up. And, doing blood pressures, urine testing, that sort of thing, feeding patients who'd had stroke, that type of thing. And so I really enjoyed that. And you get talking to people, and when you've got that confidence that things are confidential, we learn all manner of things about all manner of people, then they tell you things that they wouldn't tell anyone else. And you think it's such a privilege to be in a position where someone feels comfortable enough to tell you that type of thing. So yeah, it was a very easy decision for me, actually. I looked at pharmacy, very briefly thought, this isn't for me. And at 16, that was it. I was a doctor. And I remember my careers teacher, I won't name him, but I still remember when careers teachers, not every school had one, but they had one at my school. I think he was an economics teacher. And he said, well, what are you going to do if you don't get the grades? I'll say, I'll apply again next year. And what if you fail then? I'll apply again. And this went on till it was the point of, I said, look, I'm just going to keep applying until they say to me, stop wasting our time type of thing. And that was it. That was the sole amount of my career advice because my family, I don't come from a family of doctors. My dad's from Ireland. My mum, he's an engineer. My mum was a maths teacher. 6 children. And, we all had to work really hard. And so I worked hard, mum and dad encouraged me, and there you go, there we are. So it was I didn't have that background of, mum and dad are doctors and things. So I was somewhat of a black sheep in terms of medically, because often there's usually a lot of doctors in the family, and there were none in mine. I think the nearest was my dad's sister used to be a nurse. That was it. Didn't have anything at all. I remember them saying, no, you won't get in. But there we go.
Well, you proved them wrong.
I do. And I remember vividly my interview at Liverpool Medical School. Not one question in particular. They said, why Liverpool? And I said...
Had you applied anywhere else?
Yeah, you had to. You had to apply to 5. But the way it worked back then is you had 5 choices and you had to rank them 1, 2, 3, 4, 5. And I put Liverpool first. And they said, so,
of course.
Yeah, of course. Why do you want to come here? I said, I support Everton and I want to go and see the Blues. And these 2 professors sat there and they looked at each other and said, do you know what? No one's ever said that to us before. I thought, I fluffed my interview. But as it turns out, a lot of the consultants in Liverpool are fanatical Everton or Liverpool supporters. So it's big up there. And it was great. And it was in 1986 was my interview. So it was when it was the Mersey Cup final. And I went up with a friend who was looking to do law, and we stayed in some cheapo hotel in the city centre. And it was wonderful. Just had a great time and thought, this just feels like home. So there I was from East London up into Liverpool. and no regrets at all.
What a great story. Really great story. I could talk to you all afternoon, but I know you're a busy guy. I know you've got patients to see and work to get back to and all the rest of it. So I want to thank you very much for taking the time to talk to me today and answer all my questions.
You're very welcome.
And hopefully we can share them and people can learn a few things from them and understand what makes a respiratory professor tick, or rather this particular respiratory professor tick. And it's been great to hear your backstory. I really enjoyed it.
Yeah.
Now, how come you didn't stay in Liverpool then once you qualified?
That is a good question, and I do know why. So it was 1995, and I was at a stage, so in the medical training, it's a little bit different now, just the way that they've structured restructured the training, but you used to do your house job, then you were a senior house officer for 2 or 3 years, then you were a registrar, then senior registrar, then consultant. And so I'd done my house job and a 2-year SHO rotation in Liverpool at a hospital called Walton and Fazakerley. They're now called University Hospital Aintree, I think.
I know it.
Yeah, and so I was then at the stage where I almost went into cardiology then, because I was offered a cardiology registrar post at the hospital I was working. And I thought, my friends of my group of university friends were starting to migrate. We were gradually moving away. My group was sort of from Wales, from the Lake District, and from Cheshire. And so we were just starting gradually, and I didn't want to be the last one there. And I thought, because Liverpool can be quite a like island or insular place sometimes in medicine. I don't, as a city, it's a great city and brilliant people, but the medicine there, you'll find a lot of people have been there throughout their whole career and never moved, which is no bad thing. But, I'm from London and I did want to come back, and I didn't want to be the last person left there. And so I got a job as it happened, in Ealing Hospital, which was that job I told you about earlier. Yeah. I do remember going for one interview with a very pompous person in one of the teaching hospitals in London who was like, "Why did you ever leave London and go to Liverpool?" And I was thinking, because I didn't want to end up like that person. When you're applying for university, see the children now are I think, are much more au fait with a whole host of things. But for me, there was no internet then. And there used to be a book in the library, and I can still remember where it was in my local library, which described the university, and that was it. And it was, I can't even remember what it was called, but I remember where it was in the library. And you'd look into this thing, and you'd then see what type of things, what courses they were, what the social life was like. And even they always used to publish male to female ratios as well, which was a bit of a rat. So that you knew if you were going to be just stuck with a load of boys or whether there were lots of girls there. It was a very different time then. And so just look at what the book said, and that would help tell you about the university, and then you could get a prospectus and go to an open day, which is what I did. I went to an open day out there. So.
Wow, fantastic. I remember what my other question was.
Go on.
Now, I was under the impression that in order to see a specialist like you, the pathway to that is to go through, your local GP. Is that true, or is that a myth?
It can be. It depends. So it depends on, essentially it will depend on whether someone is insured or not. If someone is self-funding their care, they can do whatever they like. Within reason, they can go and see anybody. So if someone were paying for their own consultations, they could book in directly with me without involving the GP. I always say to patients that when I write a letter afterwards, say, can I copy your GP into this? Because it's important that they are really at the centre of the patient's care, and they will know hopefully with what other specialists might be involved, because the worst thing you want is a lack of communication, because that's a recipe for things going wrong. If someone's insured, then they don't always have to see their GP. Sometimes they might. It will depend on the company and the type of policy they've got. Sometimes what it will be is sometimes there are places that have open referrals where someone might ring up their insurer and say, I've got a cough, I'd like to see a respiratory person. And if the company approves that, they might give them 3 names. And that person can then either nesearch those 3 people or ring them up and see, it might be that it's the first one who answers, gets to go and see them. But most patients are a bit more savvy than that, and will do a bit of research and dig around and make sure that it's the right person for them. And so I think it's always useful for me anyway, for the GP to be involved, because hopefully there'll be information, particularly the previous medical history and the medication that they're on, because it can be jolly difficult when I ask people about the medicines, even if they've been primed beforehand by my PA. It's, we all can be busy and get in a rush, and then you realise you've forgotten your list or whatever. And if I've got a list from the GP that says that this person's on, 8 or 9 medications, and they've got allergies to this, that, and the other, and they had this operation and that operation, then that's really useful. So I'll always encourage them, if they will, to copy the GP, to have the GP involved. And some people have got 2 GPs. They'll have an NHS and a private, because it can be difficult sometimes getting in to see your NHS GP. And so if they may have a private GP, and sometimes that's all they'll use. But sometimes they perceive that there might be conflict, that, the NHS GP is going to be a bit miffed that they've been to see a private GP. And my experience is most people are not like that. They'll just want, and even myself as a specialist, so long as the patient gets the right result, it doesn't matter who they've seen. And I'll do that. There are some patients say, oh, can you sort this out? And I'd be like, I'm not the right person. This is something to do with your digestion or a hip injury. So yes, of course, I can write a form for an MRI or an X-ray or a CT or whatever of your hip or your whatever investigation it is. But where you need the specialist and the right person is A, knowing what's the right investigation, and B, what are you going to do with that information? Because there's no point just giving someone a pile of forms to say, go off and do these tests. Because you have this scattergun approach, you'll pick something up. And it's like, well, what does that mean? Every time I see a patient and I'll talk through the test, I'll do why we're doing the test and what we're going to do with that information. Because if I don't know before the test what I'm going to do with the information, so I'm not going to know when I've got the information. Then it's even harder. So you've got to know sort of prospectively what we're going to do and say, look, here we are. There's a crossroads that we'll come to. We can go left or right. And sometimes that can then lead to more crossroads, and you could got almost an infinite number of possibilities. But you just go through, this is where we're going. This is what I think's going on. This is how we'll try and do that. So involving the right specialist, and the specialist could be someone who's specialist in family medicine, i.e. a GP. And certainly a lot of the GPs I work with, both NHS and private, are really excellent at that holistic sort of overall care. If you imagine the sort of hub and spoke of a wheel, they're at the hub and I'm just on one spoke. And what might be at 180 degrees to could be a very different specialty.
But I mean, listening to you there, it just, it sounds like that complete picture. When you first see a patient, you're interested in hearing their story of what's brought them to you, listening attentively, because all of that history is pointing you towards the diagnosis and pointing you towards those tests that you've just talked about, and also involving them in the process of that decision making because of the impact that those tests might perhaps have further down the line. So I'm not surprised you get good scores on your Doctify, Professor Howard.
Very kind.
There's no substitute for a good patient history. That's what I was always taught.
Absolutely. It's everything. And there is the, when I remember one of my teachers when I was a more junior doctor saying about, laying hands on the patient is always an important thing, even if it's to take a pulse or a blood pressure. It's just the importance. And whenever I see people, I'll always listen to their chest without fail, because the number of patients I've seen, obviously it's my specialty, so I listen to the chest, but there will be times when it's not going to add much to it, but it's one of those things that even if it were not going to add anything, the number of patients I've seen over the years whose perception is of whatever doctor they've seen before is that they couldn't be bothered to even listen to my chest. And even if it wouldn't have made any difference, it's amazing. That might be the only thing they take home from that consultation. So I think it's really important, both you've got to be able to talk to people, and not just being perfunctory and just going through the motions, but actually having a proper listen. And I think even when it's normal, patients feel good when you can say it sounds normal. Your blood pressure is normal, your heart sounds normal, your lungs are clear. That's good. They can take that home as a reassurance.
Peace of mind is priceless. That's what I always say.
Yeah.
Well, thank you. Those are all my questions now.
Wow.
That was the one I remember. So thank you for answering that one as well.
That's all right.
Thank you for your time.
You're very welcome.
I'll look forward to seeing you again sometime.